Okay, good afternoon. Thank you for joining us. I'm really excited to introduce Dr. James Shapiro. Dr. Shapiro has been working on diabetes research for a long time, and in particular, he's credited with developing the Edmonton Protocol for human islet cell transplantation, which was published in the New England Journal of Medicine in the year 2000. He is currently continuing this research at the University of Alberta in Edmonton, Canada, and he also holds the Canadian Research Chair in transplantation and regenerative medicine. Dr. Shapiro has received quite a lot of awards, including a Hunterian Medal from the Royal College of Surgeons of England, and he has also recently been inducted as a Fellow of the Royal Society of Canada. And with that, please help me welcome Dr. Shapiro.
Frank, thank you very much indeed. It's very kind of you to invite me to Google. I've been very impressed with my tour so far, and I'm very excited about the discussions that we're going to have later on this afternoon. It's a great privilege to be here and be with you and share our hopes and trials and tribulations and progress in cellular treatments for the condition of diabetes. So we're trying to get to a point where we have diabetes cured once and for all for the future, but it's not easy to do that in one fell swoop. So we've got several strategies, and it's really a team and global effort in diabetes research to try and take the point where we have insulin today and hopefully no injections, no monitoring for the future. And I'll try and take you along that journey. Cutting-edge islet and stem cell transplant treatments in the clinic for diabetes as we move forward today. So diabetes, most of you will know what diabetes is, but just to start at the basics, diabetes is a condition where patients lose the ability to adjust their blood sugar. And there are two main types of diabetes. There are several subtypes, but two main types. Type 1, where the pancreas basically has lost its ability to make insulin. The cells in the pancreas that make insulin are called islets of Langerhans. And inside those collections of cells, there are beta cells, and those are the beta cells are the ones that make insulin. So in someone who has type 1 diabetes, then the body has basically destroyed those cells, destroyed the beta cells inside the pancreas, inside the islets that make insulin, so the patients have an absolute deficiency of insulin. And the other type of diabetes, which is of course much more common and increasing in number as well, is type 2 diabetes, where patients become resistant to insulin, and therefore when they receive insulin, or the pancreas is making insulin, the body's needs for insulin are basically what the pancreas can release is insufficient. So diabetes is a very common condition. There are about 381 million people with diabetes in the world today, based on the world estimates from the Diabetes Federation, 2013. Type 1 diabetes represents about 10% of the world population. By 2030, this population with type 1 and type 2 diabetes will double. So it's going to be a huge, huge health burden for the future. The national cost of diabetes in this country, in the US alone, is greater than $245 billion, estimated last year. And that increased from $174 billion in 2007. And clearly, with the massive increase in numbers of patients with diabetes, this is going to become uncontrollable and supersaturate the ability of the healthcare systems to deliver appropriate care. So insulin's been around for a long time, as some of you may know. Banting Best, and this is Frederick Banting in the physiology laboratories in London, Canada, in 1920, when he was working on 1921, 1922, when the team was working on the discovery of insulin, Banting, Best, Collip, and MacLeod. And insulin injection therapy clearly has been life-saving for many, many patients with type 1 and some patients with type 2 diabetes. So injections of insulin from the outside can substitute for the pancreas's ability to make insulin. And we measure insulin in the number of units. So most patients will take 20, 30, 40 units of insulin a day, and they measure the number of units of insulin as a crude amount. It was the amount of insulin needed, 1 unit of insulin, to cause hypoglycemia in a rabbit. That's how they originally discovered it when Banting and Best were working on this. Diabetes is a dangerous condition to have overall. Kidney failure is a problem, 25 times more risk than the general population. Heart attacks, 2 to 5 times more risk than the general population. Strokes, 2 to 3 times more risk. And life expectancy of patients with diabetes is at least 10 years shorter than the rest of the world without diabetes. Diabetes is the leading cause of vision loss in working age adults. It's the commonest cause of end-stage kidney failure. and of non-traumatic lower limb amputations, because the blood vessels basically become destroyed when the body's glucose becomes awry. There's been lots of improvements in the treatment of diabetes over the course of time. As I mentioned, before the discovery of insulin in 1921, 1922, diabetes was a fatal condition. When insulin was first tried in patients, it led to complications, infections, sepsis. Then there have been various improvements in different types of insulin, short-acting, long-acting insulin, different ways of delivering insulin over the course of time, including insulin pumps, including continuous blood glucose monitoring systems. And the whole idea here is to try to tighten up the sugar control so that patients are less at risk of getting the end-stage complications of diabetes, the micro and the macro complications of diabetes. And the reverse side of that equation, as we try to tighten up the control, is that patients get much more of this condition, which is an iatrogenic condition, in other words, caused by doctors, which is called hypoglycemia. So when the blood sugar falls below a certain threshold, then patients become susceptible, because the brain absolutely requires glucose to function. As soon as the blood glucose drops below a certain level, then the brain can no longer function. So islet cell transplantation has been around since the 1970s, experimentally. And first trials in patients happened in the 1980s, and really it took off in 2000, and there have been several done, and I'm going to explain and tell you the story of islet transplantation shortly. But really our indications for islet transplantation have been to try to reduce this risk of hypoglycemia, reducing the risk of lows in patients that are needing insulin. So why do we try to run the blood sugar low? This is really based on some very large trials in patients with diabetes. We know from these curves, for example, as we try to tighten up the blood sugar control, we can definitely reduce the risk of complications, such as this one on the right called retinopathy, which is where the blood vessels in the back of the eye accelerate and grow and cause the blindness. But as we tighten up the control, then patients are more and more at risk of getting lows. And we measure this by the glycated hemoglobin, which is a marker in the bloodstream that really tells you how good or bad the blood sugar control is over several months. So here's a patient that's wearing a state-of-the-art continuous glucose monitor. And you can see across day 1 and day 2, this patient has quite wide fluctuations in blood sugar control. And at 8 o'clock in the morning, on the second day, you can see the blood glucose drops. The patient is on their own, not monitored. And unfortunately, that patient's found dead in bed at 9 o'clock, an hour later, from a fatal hypoglycemic event. And fortunately, this is relatively rare, but it does happen, and it happens in young adults with type 1 diabetes that have poor control. Now, this is what we can achieve today with an islet cell transplant. In the lower panel here, you can see very wide fluctuations in blood sugar over the course of time, up until that red arrow where the patient receives an islet transplant. This is a transplant that actually is done in Miami. Dr. Camillo Ricordi shared this slide and data with me, but it's very typical of what we can achieve routinely with an islet cell transplant. And here you can see, after the islet transplant, when the patient discontinues insulin, that blood sugar control becomes very tight, is in the normal range or near normal range. The price of this, however, is that the patient needs a procedure, a small procedure to receive cells, and has to have immunosuppressive drugs in order for the body not to reject these cells. They're transplanted cells from organ donors, and they are therefore potentially foreign to the body. And also the process that caused diabetes in the first place, which is an autoimmune process, meaning the body attacks itself, this will happen again after an islet transplant to the new cells, unless the anti-rejection drugs are given. So there's been real progress in islet cell transplantation. I'll explain that to you. But I think we're somewhere along this hype cycle right now, perhaps somewhere along the slope of enlightenment. We haven't got to nirvana yet, but we're trying to get there along the plateau of productivity. And still, I think if you can read and you can Google lots of negative reviews on islet transplantation, because I think the knowledge in this area probably hasn't reached all of the community. But I'm sharing with you today some of the progress. But there's been progress throughout diabetes. And here, for example, is a trial that was just completed in September last year, looking at a special insulin pump that switches off when the blood sugar reaches a certain low threshold, a low glucose suspend. And when this is applied to patients, then the risk of the patients getting hypoglycemia is certainly a lot less than it would be otherwise. So there's been lots of progress. And I'm also very excited this afternoon to meet with your Google Contact Lens team, because I think the areas of monitoring for blood sugar control and our ability to monitor the function of our cell transplant therapies over time with this kind of technology will be enormously informative and allow us to tighten up our control, minimize the stress on the cells, and allow us all to learn a lot about controlling diabetes. So who do we offer an islet transplant to today? We have two real major categories. Those with patients who have an islet transplant alone. In other words, they haven't had a previous transplant. They have to have type 1 diabetes for more than 5 years. They have to fail on all the standard therapies, including insulin pumps if available. And we have various scoring systems, which I won't dwell on, but basically that demonstrate that a patient has severe lows despite their ability to control the glucose as best they can. And about 5 to 10% of the population with type 1 diabetes, at least in Canada, would fulfill these very strict criteria to justify adding immunosuppression and receiving a cell infusion. The other side of the equation is patients that already have a successful transplant, like a heart, a lung, or in this case, a kidney transplant. So they're already on the anti-rejection drugs, so they don't have to face any additional risk except from the minor risk of the procedure required to put the cells in. And islet after kidney transplant, our second category, is becoming a very successful category too. So we began with the Edmonton Protocol in the year 2000. It didn't just begin from nowhere. It began from 30 years of research in small and large animal models, and a terrific collaboration with several international centers across the world. And I think that's one of the privileges involved in science and in diabetes research, is that we have a very, very close-knit community of scientists working together, willing to share information and ideas to allow us all to get to the next step. And it probably is modeled very nicely in the Google organization. So we published this in 2000. This is in the New England Journal of Medicine, where our first 7 patients receiving islets under the Edmonton Protocol, that we called subsequently the Edmonton Protocol, where all of the patients that had the transplants were able to come off insulin and remain off insulin for a period of a year. And in fact, now 15 years later, 2 of the original 12 are still completely insulin-free with full function. And we've just refined this treatment over the course of time to try and further improve it. So this was what we called the Augmented protocol. We gave 2 sets of islet infusions, initially around 5,000 islets per kilogram based on the recipient's weight, and then we gave another infusion to provide enough cell mass to make it sufficient insulin for the patient. And we gave these 2 anti-rejection drugs, sirolimus and tacrolimus, and an antibody at the beginning. And we subsequently changed these drugs now to more standard drugs because we encountered quite a lot of side effects from this sirolimus drug, but it was certainly very successful in allowing us to begin our first trials. We then replicated these trials in Miami, Minnesota, and in our own site in Edmonton in 118 patients, and were able to replicate this quite successfully in 82% of patients coming off insulin. And then we moved forward with the Immune Tolerance Network and carried out a large international trial in the US and in Europe, testing the Edmonton Protocol, and we published that too in the New England Journal. So where are we today? So we've treated in Edmonton over 200 patients, 218 patients, who've received 460 transplants. So you can see that most patients require, in our center at least, 2 islet infusions to provide sufficient mass for them to come off insulin for periods of time. And we've received in Canada patients from all across the country. Last year we did a record number of islet transplants in Edmonton. We did 66 islet transplants in Edmonton, and we're quite proud of that. We've kept our teams very busy. Across the world, currently there have been over 1,000 islet transplants done at least 30 different international sites. And so I'm going to explain to you now how we get the islets out. And that was a picture, by the way, of islets under a microscope stained with a dithazone dye that stains the zinc, because zinc and insulin are very closely linked. Staining the zinc inside the islets so you can see them quite clearly under the microscope. Those are very pure islets ready for infusion. But we don't just get the islets from anywhere. They come from a human pancreas. So I'm just going to walk you through this process because it is quite a complex process that our team has to do in Edmonton. So here they take a pancreas, they cannulate the pancreas duct, and I'll just show, as they're going through the video here on the right, I'll show you the graph on the left there is all those little dots that look like the stars in the night. Every one of those represents over 1,500 islet isolations done by our team over the last 15 years. And there's a human pancreas on the right. You can see it being distended with collagenase enzymes before we chop it up and put it in Camilla Riccordi's chamber. So there's Doug shaking the chamber there. This team's a very well-knit team. They work day and night to prepare the cells. Once the cells are digested, then we purify them on a continuous Ficol gradient on a cool Kobe machine. And there's Doug Tatsuya and the team in Edmonton that prepare these cells for us, and they've done a terrific job for us. You can't see that graph on the right, it's a little too small for you, but basically the number of islets they get out of the pancreas today is double the number that we were able to get in 2000 when we first began the Edmonton Protocol, and their success rate in being able to take a pancreas and provide enough cells to transplant has also increased to around 60 to 70%. The actual transplant part is very, very simple. It doesn't require a transplant surgeon to do this, fortunately. So the transplant's done in the X-ray department under local anesthetic for the patient. Here's a patient who's awake, chatting away during the procedure. We use fluoroscopy X-ray so we can see where the needle goes. We thread a catheter into the main portal vein there, and then we simply drip the cells in under gravity. And we measure the portal pressure while we do this. We give heparin to prevent blood clotting. And at the end, before we pull that catheter out, because we learned this perhaps in our first early cases, when we pulled the catheter out of the liver, we initially got bleeding. So we found that when we put this paste in along the tract, as we pull it out, we mix it up with contrast so that we can see it being injected on the X-ray screen. You'll see that in a second here as we load the syringe. This is Avitine paste. So as we pull the catheter out, we plug the tract in the liver, and that has eliminated the risk of complications such as bleeding after the islet transplant. So this is a very safe procedure. And if we look at the number of patients we've treated over the course of time now, 97% patient survival, and these are patients, of course, who've had long-standing diabetes who are at risk of many different things. And of the few deaths that we've encountered over 15 years have been mainly cardiovascular deaths in patients with long-standing diabetes, so heart attacks, basically. So we've had 4 patients die of heart attacks. One patient had a possible Creutzfeldt-Jakob disease, and one patient had a fatal hypoglycemia after an early transplant where the cells failed. So none of these deaths have been related to the transplant or to the anti-rejection drug treatment to date. So this has been a very safe transplant. It's certainly the safest transplant that I've been involved in. There have been adverse events. I can go through these, but I won't go through them in too much detail. A couple of patients over 15 years, 1.4% needed to go on to get a kidney transplant because the drug we give to prevent rejection, tacrolimus, does have kidney side effects. Now, what about performance? Are we doing better over time? So if we look at the function of our cells over time, in the red line here, which is, so every molecule of insulin that's made by the cells, another molecule is made called C-peptide, and we can measure the C-peptide in the bloodstream with a simple blood test. So you can see that over the course of 15 years, 73% of patients continue to make C-peptide to a sufficient degree that controls their hemoglobin A1C, therefore reduces their risk of getting the complications of diabetes and prevents the patients from getting hypoglycemic events. So this is a real advance, particularly for patients that have really recalcitrant risk of hypoglycemia, so that these patients are very well protected. But what we did see in the early Edmonton Protocol series is that a large number of patients did need to go back onto small amounts of insulin, around 15% of patients by the 15-year mark. And so we've spent a lot of effort now in the last several years seeing if we can improve these results over the course of time. And if you can think of the number of the cells that we transplant into the liver here as a bucket, and the cells are being lost through little holes in the bucket, we've been working in science to see if we can plug the holes in the bucket to try and allow more cells to survive over time. So we've been looking at various pathways to reduce early damage of the cells, trying to prevent them from being rejected and preventing late graft loss, and then really trying to improve the number of cells that we put in at the beginning so that we can have many, many more patients with fuller function and more durable function over time. Now, because the diabetes, type 1 diabetes is an autoimmune condition, as we mentioned at the beginning, there is a risk of the autoimmunity coming back again. And here's a patient's biopsy, and I won't go through too much details, but you can see on the right-hand side there are islets surviving quite well, but no beta cells in that biopsy. This is from Dr. Rosini's group in the University of Massachusetts. So we need processes that can control rejection, reduce inflammation, and allow the patients to become tolerant. In other words, for the future, we'd like to have a cell treatment that we just put into the patients that the patients won't reject on their own and won't need a lifelong anti-rejection drugs. And we're all trying to get to that point where we can achieve that. And controlling this triangle is a bit of a challenge, but we're working on it very intensively as a global community of diabetes research scientists. And we're trying various different maneuvers, and I'll mention a few of them. I won't go through the details, but I'll mention a few of them that we're trying presently in Edmonton. Now, I showed you that fall off in the insulin independence rates at 5 years, and now there are at least 6 centers across the world that have insulin-free rates with islet cell transplant at 5 years, more than 50%. And this is an important milestone because it's exactly the same rate that we would see with a whole pancreas transplant alone. So a big operation in comparison, putting a whole pancreas transplant in, connecting the blood vessels up, and the risks from that. We can achieve today, at least in these 6 centers, very similar to results to the whole pancreas transplant alone with a simple injection in the side. So in trying to control the immune response, we've tried this treatment in Edmonton now in over 100 patients, if I update those numbers, in over 100 patients in various different protocols over the course of time. And what we found in our earlier analysis is basically, if we look at the C-peptide rates, they're very similar, perhaps a little bit better with the Alemtuzumab than they were with the Edmonton protocol, 84% at 7 years with C-peptide function. And if we look at the insulin independence rates, and these are patients that are fully free of insulin, again, ongoing data still in analysis phase, but 58% of our patients, when we last analyzed this, at 7 years were still free of insulin, significantly improved from our original Edmonton protocol data, where currently at 15 years, just 11% of patients remain insulin-free. Now, I mentioned the hemoglobin A1C, the glycated hemoglobin, this marker in the bloodstream. It tells you how good the blood sugar control is. And you can see at the beginning where it says pre there on the left-hand side of your screen that the levels are around 8 or 9%. And the red line is the sort of threshold of what a normal person would have who doesn't have diabetes. Now, as we bring the line closer and closer to the red line, then the risk of getting secondary complications is obviously reduced markedly. But normally, if we did that with injected insulin from the outside, the closer we got to the red line, the more and more dangerous hypoglycemias a patient would have. Well, after the islet cell transplant, we can achieve below the red line or on the red line very reliably without the risk of hypoglycemia. And these graphs show you the different measures that we use beforehand. You see the patients have a sky-high risk of hypoglycemia. On this score, it's about 5 on that score. On the hypo score, it's around 1200. And afterwards, you can see it's almost undetectable over the course of time. So patients are completely protected, so long as the cells continue to function, from hypoglycemia and swings in blood sugar. So this is a very effective treatment for controlling blood sugar.
I feel my control now is the best it's ever been in 20 years.
What about the risk of the secondary complications? There are several centers looking at this. Garth Warnock in Vancouver has looked at this quite closely. What he finds in a control group with islet transplant versus conventional or best medical care insulin therapies, that the islet transplant group has much lower hemoglobin A1C in the green. They have less risk of eye disease, and their kidneys are actually protected despite the fact that they are receiving tacrolimus. So this is very encouraging data to suggest that an islet or other cell transplant or stem cell transplant in the future for diabetes will have these similar effects, being able to protect against the secondary complications of diabetes. We're working with the US FDA quite closely in 2 major trials as part of the Clinical Islet Transplant Consortium. One is called CIT-06 and one is called 07. And basically, to make it very simple, one is islet after kidney transplants, and the 07 one are islet alone. These trials are now completed, are undergoing a very detailed analysis with the FDA. And very likely, these 2 trials will lead to the FDA awarding a biological license for islet transplantation, allowing Medicare, Medicaid, and third-party payers to potentially reimburse islet transplant in the US, which has been a major limiting factor in the terms of the numbers of cells transplants done in the US. We've been very fortunate in Canada, however, to have the Canadian government pay, and the Alberta government, I should say, pay for the Canadian transplants to this point. And a similar thing has happened in the UK, with the National Institute of Clinical Excellence paying for islet transplant through the UK government. Same thing in Australia, same thing in Europe and Geneva, and in several other countries. So hopefully this will happen very soon in the US. Several groups have reported the ability to achieve what I showed you with 2 islet transplants with a single donor islet infusion. And this would be important because it would allow twice the number of patients to receive transplants from a limited donor source, from organ donors. And so several centers have been able to do that with different strategies. But still, this is a challenge, I would say, for us. Only about 10% of our patients in Edmonton are able to achieve insulin independence routinely if we don't select the donor and we don't select the recipient tightly. But what we do find, if we look at Melina Bellin's analysis, looking at all the patients treated that are participating in these centers, that at 5 years, if we give an anti-inflammatory treatment at the beginning called etanercept, which prevents an inflammatory agent called TNF, if we switch that off at the beginning, we can have many, many more patients off insulin at 5 years. Seems to be very important to suppress inflammation at the beginning. So we've done studies in mice. We always take things back to mice and test things. And we tested another compound called anakinra, which is another antibody, which is also an anti-inflammatory one used in inflammatory bowel disease and another condition called psoriasis. And we found that this is a very effective treatment to allow human islets to engraft in mice. And we've been able to take that treatment across to the clinic and treat many patients that way. We've also been trying to switch off the cell death pathways in this pathway called apoptosis. So cells die by different processes, but we've tried several agents to switch off cell death. These are called pan-caspase inhibitors because they switch off all the major cell death pathways that lead to this apoptosis. And when we've tested these in our mouse models and our pig models, we find that these caspase inhibitors can reduce the tiny number of islets needed to reverse diabetes by about 80%. So they make a big, big difference. And we've tested this several times in various different combinations in various different ways. And we moved on and carried out a early clinical trial with these that looks, well, at this point, it's difficult to say whether it's had a big impact, but we're still working on it. So we recognize today that islet transplantation, the way it is today, because patients need immunosuppression, because there are a shortage of organ donors, can only really address a very narrow band in the spectrum of patients with diabetes. And we'd like to get to this point here where we can treat all the patients that are just diagnosed with diabetes, that have difficult to control diabetes, that have chronic type 1 diabetes, and also those that have type 2 diabetes, so the entire spectrum of diabetes. And we recognize that if we keep going the way we're going on that one track, we won't be able to address the entire spectrum. So what next? So we're looking at alternative retrievable sites to put in islets today or stem cells potentially tomorrow. And here's a trial that we're actively involved in now with a company called Sonova. And this is a device that goes under the skin. It looks the size and shape of a tea bag. And it basically threads in under the skin. We leave it there for about a month or two. And while it's under the skin here, the body makes new blood vessels that grow in. And this is a sort of in response to a foreign body. Then we take those rods out when we come back. And we can do this under local anesthetic, we can do it under a short general anesthetic, and then we can infuse our cells along that track and basically put the cells under the skin instead of in the liver. Now that may be an advantage, but as we think to the future, as we think about use of stem cells, it might be safer to put them in a retrievable place where we can take them out if we need to. So if we put them under the skin instead of the liver, it's a much simpler maneuver to take the cells out. So we've done this so far in a few patients, and it's looked somewhat promising in terms of being able to show cell survival, but this is still ongoing, and we're still looking at the data closely. We've also been looking at what we call the deviceless method, so we've been putting cells we put a tube under the skin, we leave the tube under the skin, a simple catheter that we use routinely in the X-ray department. We leave that catheter under the skin for a month, we take the catheter out, and then we put our cells in, or stem cells, or islets, or whatever kind of cell population we want to put in this tract, which has now got lots of nice new blood vessels. And here you can see islets surviving in that round area that used to have the little catheter on the top left there, and the cells work very well. And you can see, and after with the catheter placed under the skin, and then we put the cells in the blue line, blood glucose comes down quite nicely. It takes a few weeks to do so, and you can see on the right we get lots of nice new blood vessels growing in to supply these cells. So I mentioned islet transplants today and stem cells tomorrow. So I think we're getting very close now to being able to move forward with stem cell treatments instead of islet cell transplant treatments for the next round of trials for the future. There are several groups across the world working on stem cells. I'll show you first just one that we're collaborating with. So Maria Nostro and Gordon Keller in the University of Toronto have made a stem cell line that makes human insulin, the human beta cells basically from stem cells. And we've been able to reverse diabetes quite effectively in mice in our deviceless model with their cell system. We've also been testing out to see if the cells turn out to have what's called a teratoma or a risk of awry cells, then they can be transplanted still in this deviceless space and not breach the space, so we can still potentially remove them. We've also been working for the last 10 years with a company called ViaCyte down in San Diego, and we've been very excited by their progress in developing a human embryonic stem cell line that they have shown can reliably make human insulin and can be potentially transplanted and can cure diabetes in mice when transplanted. And this group has been very innovative and shown these cells to be safe, to have no risk of that teratoma that I mentioned. And they are now carrying out a clinical trial that we're looking forward to participate in, where we're going to put these cells inside what's called an immunoisolating device so that the immune system can't directly get cell-to-cell contact with the transplanted cells. And the idea of that is that we wouldn't have to give the anti-rejection drug treatments if it's effective. So we're looking forward to starting these trials with ViaCyte within the next few months. Now, in parallel, there's lots of other treatments that could potentially switch off the autoimmune pathways in type 1 diabetes. And Jeff Bluestone from San Francisco here has summarized all the different pathways that can be switched off in type 1 diabetes, all the studies, all the antibodies, all the drug treatments that can be given to try and control diabetes. And it's obviously a very complex one. We've amassed a team in Alberta to try and address one or two of these together with industry, and a large collaboration of scientists in Edmonton and in Calgary. And we're going to do two different trials. One is trying to get patients' own stem cells to regenerate their own pancreas as soon as the patient is diagnosed with diabetes. In other words, resetting the immune system and getting the cells, the patient's own cells, to turn back and repair the beta cells. And then the second strategy we're using is the ViaCyte cell transplants to try to treat patients just like we would with the Edmonton Protocol type treatments that I showed you about. So the immune reset is moving forward. We've got our plans in place. We're just putting this through ethics and through Health Canada right now. We're going to give antibody treatments at the beginning to reset the immune system. We're going to take the patient's own bone marrow cells and retransplant those up into the pancreas to allow those cells to repair the injured pancreas. And then we're going to give a treatment for the first year called a GLP-1 analog that will help to further regenerate and accelerate the growth and repair of the injured islets. So we have a lot of things to do, and we're very, very excited about it. We're also working with another technology called normothermic perfusion, and this is going to, I think, revolutionize all areas of transplantation. So most of the time, you can see in those boxes on the right, that's how we carry organs around in ice. So hearts, lungs, livers, kidneys, and the pancreas for our islets, we carry them in these boxes. So we're just about to start a trial with a group in Oxford, University of Oxford, and a company called Organox, where they have one device that we can put a liver on, which is in the bottom left panel. There's other companies that have a device for hearts, for lungs, and here's one that we're testing out for pancreas transplantation. So in other words, instead of putting the organ in ice and having it injured, we can keep it perfectly alive, like the heart's beating there, outside the body. And so we can put it in, as soon as we transplant it, it can be in perfect condition when we transplant these organs. It'll make a big, big difference to the safety of transplants, and also to make sure that the transplants really work before we put them in. And the idea here is that we can deliver oxygen, deliver nutrients, provide a physiological temperature, and provide an ideal environment for the organ while it's outside of the body. So we're very excited about this technology as well as we move forward. And this is the liver machine that we're about to test. And the company who is here in San Diego, came to San Diego to the World Transplant Congress, mentioned to me that they'd love to have Google's logo on the outside of the box. So if you're interested in working with them, please let them know. So let me sum up. So I've showed you that we've made a lot of progress in the treatments of diabetes over the course of time, that our insulin independence rates have improved a lot, that several centers now have over half of their patients still free of insulin at 5 years after an islet transplant, that we're looking now to other alternative sites for infusing islets under the skin. I didn't mention other sites that we're about to test with the Pittsburgh group, including the lining of the stomach. We're about to start trials with ViaCyte on embryonic stem cell treatments, and we're also looking at regeneration trials to regenerate and repair the pancreas and the islets. At the moment, a child or adult is diagnosed with type 1 diabetes. So there's a lot of things happening, and I think we'll make a lot of progress. So finally today, I'm very much looking forward to discussing with the contact lens team our opportunities of working together in cell transplant monitoring, and also with the Google Glass team, looking at the role of the Google glasses in state-of-art monitoring in complex surgeries. Pierre was telling me about the use of these in lung transplantation. I think we could apply this very easily also in liver transplantation, maybe during the pancreas isolation. And I think also this could allow us to communicate far better as scientists from one institution to another. So instead of me being in Edmonton, another group being in San Francisco, another group being in Australia, another group being in China, we could make a scientific community that is basically global and one, and allow us to work much closer together, and that's what I'm very excited about. So on behalf of our preclinical team scientists that have done all the hard work, our PhDs, our master's students, and our postdocs and technicians that have done really all the hard work in preclinical testing, on behalf of our large clinical team that has basically helped us prepare the islet transplant. So thank you very much indeed for the opportunity to present to you this afternoon. I look forward to answering your questions.
My name is Zach. I actually work on the iris, basically the contact lens project here. So I have some questions about the cells you infuse. So can you tell us some very basic biology of those cells? So when you inject it into the blood vessels of the kidney, where do they end up? So they actually stay there, live in the kidney, or they eventually end up in the pancreas?
So the question is, so we transplant our cells inside the liver. So it's an injection, local injection, literally in the side like this, under X-ray, and we get the radiologist to put a catheter into the main vein that goes up into the liver. It's called the portal vein, and it's like a tree. It has main trunks and it has little branches. And the islet cells are they vary in size from about 50 microns to 150 micrometers in size. Some of them are larger, 400 or 500 micrometers in size. And basically they go up this tree, and they'll go far along the tree until they get into a blood vessel that's smaller than they are, and then they get trapped. And basically blood vessels, a little bit of blood clot forms around them, and a local inflammatory reaction occurs. Then new blood vessels grow inside the liver. The cells are not going back into the pancreas. You could potentially put them in the pancreas, but it would be very, very technically difficult to do so. It would be risky, it could cause pancreatitis, it could be a difficult place to put them in. It just so happens that the liver is a very effective place to put these cells.
So they can grow basically almost anywhere, like we are trying other.
Potentially they can grow anywhere. The question will be, will the cells work as effectively at another site as they do currently in the liver? We don't know that yet.
How do they communicate with the body? How do they know when to generate the insulin?
How do they communicate with the body is the question. So the islets have sensors on them. So they have glucose receptors, and they can sense the blood sugar, much the same way as you do a skin test and take a drop of blood. Well, they're listening to the bloodstream, monitoring it constantly, all the time. And as soon as the blood glucose goes high, then in concert they all release just the right amount of insulin that's needed, as the blood in a very dynamic way. And as the blood sugar drops below a certain threshold, they all shut off, so that they stop making insulin. So it's a much more precise. What your body, a normal person, has a much more precise way of regulating blood sugar than if you inject insulin from the outside. So it's able to do that because there are a collection of cells there that adjust insulin. And I didn't mention the islets have several cell populations in them. They have the beta cells that make insulin. They also have another cell population called alpha cells that make glucagon. And glucagon makes the blood sugar go up. So you have what's called counter-regulatory control. So with counter-regulatory control, you can keep your blood sugar in a very precise balance.
Hi, Dr. Shapiro. My name's Joel. My wife has lived with type 1 diabetes for nearly 40 years, and she had a couple questions. The short one is, do you transplant the entirety of the islet or just the beta cells? And then the more interesting or more complex question is, are you modifying the islet cells prior to transplant to reduce the chance they will be attacked by the same antibodies that originally killed off the islet cell?
Right. So the islets that we transplant are the collection of all the cells. So there's 5. I mentioned 2 cell types. There's actually 5 or 6 different cell types. Maybe there's even more that we haven't discovered yet. But the islet is a sort of an organelle collection of several types. We think that the islet needs all of those cell types in order to survive in the longer term. If you just took out all the beta cells and transplanted them, they might work for a while, but maybe the beta cells on their own, without the rest of the supportive matrix and the ability to communicate with each other in the sort of that local node, maybe they wouldn't work as well. We don't know that, but we transplant all of the cells. And sorry, the second question was?
Do you do anything? Do you you modify the islet cells prior to transplant?
Do we do anything so the islets are taken out of the pancreas in that process. We keep them in culture. Now, in the old days, the very first experiments were done. There was a lot of different, really innovations that were done. You could treat them with ultraviolet light, you could treat them with X-rays, you could treat them in high oxygen. And these would alter what's called the immunogenicity, or the ability of the body to recognize them as foreign. We haven't done so much of that now, but potentially you can do a lot of things to manipulate the cells in the Petri dish that could alter the ability of the body to recognize them as foreign. We could wrap them in a seaweed membrane, allogeneic microcapsule. We could add other products locally around the islets to protect them. So an islet in some way has a lot more potential than the other transplants that we do, where we don't have that ability to alter them in the dish. But we haven't explored that perhaps to its full potential yet. You're quite correct.
I noticed in one of the slides that the A1Cs that were reported or that were monitored in your patients seemed to improve over time after the transplant, not just initially. And given the propensity of these cells to degrade, I was surprised that it got better as time went on.
Well, I think that's partly a function. Why does the hemoglobin A1C not drop? It doesn't drop immediately. The reason for that is it takes 2 or 3 months to have an effect. So if you have bad control and then you suddenly go to perfect control, the next A1C you test is reflecting what happened 3 months earlier. So there's a lag in its ability to measure. It's designed that way because it's meant to tell you what's happened over the last few months. So that's why you're seeing a delay. It's not so much that the control is improving over time, but I think it's more that.
And just sort of a more general follow-up. I've been diabetic for 25 years, and ever since I was diagnosed, I've been following, the news media, and it basically, the light at the end of the tunnel has been there the whole time. It does seem to be getting brighter, but what is your take on kind of a realistic timeline for, I realize that's all speculation, but.
Yeah, so if I send you back to your office this afternoon and Google and say, I want you to tell me in a week how long it's going to take to finish a project. Maybe you've got all the algorithms straightened out and you can tell me it's going to take exactly a week. I think for this, because it's a biological system, it's working in humans, it's not just all of that. We also have to deal with the regulatory agencies. As soon as we want to do something different, we've got to justify what we're doing. They often tell us to go back and do more experiments. So you'll notice, I never mentioned the 5-year cure. I never said, well, we'll do this in 5 years, we'll do it in 10 years. What I will say to you is that in 2014, we're doing far more in this year than I ever dreamed we would be at this point. So my impression is that all of us as a community are moving faster. We haven't got there yet. I don't know how long it's going to take to get to the light at the end of the tunnel. And I know that's where we want to be. But it's going to take what it takes, provided we're all working intensively in the right direction.
My name's Stephen. I also work on the contact lens project. So I have a question a little bit related to Zach's question. The islet function is said to be modulated by the autonomic nervous system, the parasympathetic and sympathetic nervous system, alpha and beta cells, insulin and glucagon production. So if you place these cells underneath the skin, what's the effect of breaking the autonomic link? So you have some autonomous function in response to glucose, but you cut off this nervous system link. So
right, so you're quite correct. So the islets that are transplanted are completely denervated. They don't have any nerves going into them. Potentially the nerves can grow in over time along with the new blood vessels happen first. Potentially they can become innervated. But the nerve ingrowth isn't essential. So perhaps it helps with acute release of insulin in a normal individual who's stressed. But most of the time, these cells can respond very effectively to the local environment, so you don't need innovation. And they clearly can work just fine, as I showed you, without innovation. You can divide the vagus nerves in patients that don't get diabetes. Often we do that for other conditions. So it clearly plays a role somehow, but it's probably a very minor role because it's completely redundant. You don't need it.
So there was a research article that I came across recently about activating islet cell production in the gastrointestinal tract. I was wondering if you could talk about that. I don't recall seeing it on the slides.
So there's a group led by Dr. Tim Kiefer in Vancouver who's worked on trying to convert the cells in the gastrointestinal tract into becoming insulin-making beta cells. That's really his area of expertise. He's made a lot of progress over the course of time, but I don't think I can, beyond that, comment directly on his work because I haven't been directly involved in it. But it's exciting.
How does the life look for the patient after the transplant in terms of taking the immunosuppression drugs, and what's the cost of it and how often it has to be administered, and what are the side effects of it?
Right. So the standard anti-rejection drugs are usually taken twice a day. And most patients tolerate these extremely well. And we do a lot of testing beforehand to weed out the odd patient that won't tolerate it well. So we look for patients that have bad kidney function, and we won't give them a transplant because we don't want to push them into kidney failure. But it's usually a twice daily drug regimen. Most patients tolerate it quite well. Some people get a tremor in the hands. Some people get some leg swelling. Some people get mouth ulcers. There's various different side effects. The whole panoply of side effects can happen. But generally, most patients tolerate them well. One thing we've done here, though, in the islet transplants is to avoid the steroids. So steroids used to have a lot of side effects after a transplant. Would give you puffiness in the face, actually cause diabetes in some patients, cause overweight, cause various issues, so mood disturbance. So we're not giving any steroids at all in the islet cell transplants. So the side effects are probably minimized because of that. They're not zero. And the side effects that you don't see but you worry about are the risk of cancers and the risk of infections. So those we tell every patient coming in that they have an increased risk of certain cancers, skin cancers, blood cancers, and certain infections that could potentially kill them. And the way I look upon it and discuss it with the patients is if they have bad control of their diabetes anyway, then the risks attendant to the drugs are actually a drop in the ocean, very small compared to the big risks they face every day from their diabetes. If they have perfect control of their diabetes, then it's a different matter. If they're well controlled with insulin, and then on the other hand, I would say, well, you don't want to face the risk of infection. You don't want to face the risk of increased risk of cancer if your diabetes is being managed perfectly the way it is already. And that's really the rationale for us picking the worst of the worst patients in terms of their blood sugar control. Insulin is, of course, very cheap. The immunosuppressive drugs can be expensive. The costs are changing over the course of time now because all of the patents on these earlier drugs have ended, so that there are generics coming in and the costs are coming down. They're still not zero, and it depends on the patient's drug plan and their ability to get reimbursed for it. So in Canada, most of the time it's not been a problem. Occasional patients have not had full coverage for their drugs, but generally it can be managed.
Hey, could you comment on the transition from islets to stem cells? How do you make them differentiate into the right thing? And does it happen inside or outside of the body?
Stem cells are, of course, exciting in many ways because it means that instead of relying on going through that complex process of making the cells, you have a limitless supply that could treat the whole population in the world with type 1 and type 2 diabetes. That would be really, really exciting. But as you move forward, you've got a whole new gamut of testing to do. You have to be sure they're going to be safe. You've got to be sure that when you put them in, they're not going to cause uncontrolled drop in blood sugar. We don't think that's going to happen, but it could. We've got to be sure that they're not going to turn into cancers or precancers or some other worrisome transformation once we transplant the cells. We know that islet cells, when we transplant them, stay very stable. But these other cells, these stem cells, they can turn into any cell potentially. So there's a lot of caution as we move forward, as well as a lot of excitement. So it has to be done very carefully, step by step. Can we make the cells differentiate and make them into perfect islets and stable islets before we transplant them? And that's what we'd like to do, but the stem cell scientists that make these cells have not yet been able to completely overcome that hurdle. So they're giving us, or the cells that they manufacture, are still these pre-islet cells, and they turn into islets once they're transplanted. So they're working very hard at trying to understand the messaging systems in the body as an embryo grows, what controls the differentiation, what controls the stabilization from one step to the next. And I think until they've done that fully, we'll probably still be transplanting these precursor cells for a little while until we have ideally we'd like to have perfect human islets, look human islets, they taste like human islets, they work like human islets, and they stay that way forever. But I don't think we're there yet, and perhaps we'll never get there, but hopefully we will.
I understand that when you were first doing trials, you were using the worst case scenario patients, terribly brittle diabetics, in whom you were hoping to provide some relief without causing long-term complications from all of the immunosuppressants and kind of robbing Peter to pay Paul. So I'm wondering now in the current trials if we're starting to broaden those inclusion criteria a little bit, or where are we now with that?
We haven't really broadened the criteria. It's a very fair question. We haven't done that. We've still concentrated on the brittle patients. Occasionally we'll see a patient come to us and say, I'm just tired of having diabetes. I'm tired of testing. I've worked pretty hard at it. I'm tired of it. But my control right now is pretty good. That's a hard one for us because we say, okay, yeah, we understand where you're at, but we don't want to do any harm to you. It's so much easier to take somebody who's you've worked on, you've tried, despite your best efforts as a diabetes endocrinologist to control them. If you fail, then there's nothing else left, and it's easy for us. So have we reached the point where we could transition and open it up to more patients? And I think we probably have. I think now, at the beginning, we didn't know what the real risks were. We didn't know what the risk of clotting off the vein in the liver, the portal vein thrombosis would be. We didn't know the risk of bleeding, the procedure risks. We knew there would be a risk of cancers and life-threatening infections, but we didn't really have a quantification of it. I think now, I've shown you data, I think we do have quantification of it. So we could have a very fair, informed discussion with the patient and say, look, these are the real risks. These are the potential benefits to you if you like it, sure. And I think to get to that point, we probably need to do a randomized controlled trial. Best insulin therapy against the islet transplant, and you come in with a ticket at the beginning, you either win an islet transplant or you win a pump. And the problem with that, we want to do that trial. We'd all love to do that trial. The problem is who's going to fund it, who's going to pay for it, and we don't have anybody that's come forward to say, yeah, we really want to do that trial. We'll fund it for you. Maybe Google would.
What would the cost of a trial like that be? And not that any of our budgets can cover that, but and also, if we're wanting to donate to diabetes research, are there any organizations that you think are particularly, maybe excluding yours to be unbiased, although you can mention it, that you think would be particularly useful?
Okay, well maybe I'll answer the second one first. So there are several organizations, international organizations that raise money for diabetes, Juvenile Diabetes Research Foundation, the American Diabetes Foundation, Canadian Diabetes foundations, and many others. So I don't know if I can concentrate on one. It wouldn't be fair for me to do that. But what I will tell you is that in order to get to this point, we've all done a lot of research. And in order to get to the next point, we've got an enormous amount of research to go. And I'm not sure that any of these organizations, including the NIH, including the Canadian Institutes of Health Research, including several other global funding research organizations, we're challenged. We don't have sufficient funds to accelerate this, and so, yeah, we need funds. So if we wanted to do a trial, and let's say we powered it reasonably with 5 or 10 years of follow-up, we looked at complications, and we wanted, ideally, probably 50, 60 patients in each arm. In the control group, patients would be receiving standard diabetes care anyway, but they would need extra testing. And in the islet transplant group, in Canada, it costs us $75,000 per transplant. 2 transplants, $150,000 in the first year. Probably some additional research costs per patient, so $200,000. I don't know, if you wanted me to guess, it's the order of maybe $10 million. $10 to $20 million, perhaps. I'd have to work it out more, but it's not billions. It's doable, yeah.
Okay, and with that, thank you all for coming, and thank you very much, Dr. Shapiro, for taking the time to speak to us today.